All right, good afternoon, everybody. Thank you so much for joining us for this very timely and important discussion. My name is Jessica Scullin. I'm with the U.S. Department of Justice Office of Community-Oriented Policing Services. Today, more Americans die from drug overdoses than from motor vehicle crashes. In 2014, the Centers for Disease Control and Prevention reported over 28,000 deaths from prescription opioid and heroin, with the majority being from prescription medications. This set a new record for deaths from these drugs. Many agencies and officers know from experience that this is not a problem that we can arrest our way out of. Recently, we've seen the national dialogue about how to treat persons with addiction increasingly shift focus from treatment rather than punishment. This panel will highlight some of the nation's most successful programs and partnerships between law enforcement and the public health community in addressing the opioid epidemic. Today, we will hear from John Rosenthal, who in 2015 partnered with former Gloucester Police Chief Leo Campanello and co-founded the Police-Assisted Addiction Recovery Initiative to support the Gloucester Police Angel Program and help other police departments around the Commonwealth and the nation address the deadly epidemic and disease of opioid addiction through pre-arrest referral program. Within 24 months of its founding, the Gloucester Angel Program placed more than 560 people into treatment. More than 300 treatment centers have partnered, offering scholarship beds, and more than 275 police departments across the country have replicated all or part of the Angel Program, placing an estimated 10,000 people into treatment. Today, we will also be hearing from Major Brian Johns of the Dayton Police Department and Emily Sirico, who is the Program Manager for the Crime, Safety, Health Prevention Initiatives at the East End Community Services in Dayton, Ohio. Emily and Major Johns will discuss with us some of the successful partnership programs that they have implemented in Dayton, and will share with us some of the lessons learned that have emerged out of their work together. Our hope is that some of the discussions we have here today will help other agencies think about how they can develop similar partnerships based on some of the lessons learned and best practices set forth by this initiative. I do want to just point out that in the back of the room, we have some resource materials available for you all, both from the COPS office and from some of the presenter programs, so please help yourself to taking those. We have a lot of ground to cover and not a lot of time, so without further ado, I'm going to turn the floor over to Mr. Rosenthal and kick off our discussion. I'll give you a warning.
Hi, everybody. Thanks for being here. I am a business person in Massachusetts, and I co-founded the Police-Assisted Addiction Recovery Initiative. And it wasn't the first nonprofit I started with law enforcement, and I just can't thank you all enough for your service. We ask you all to do far more than you should have to do, and largely you're picking up the pieces as a result of bad public policy that leads to bad public health outcomes, and then we expect police to fix it. It isn't fair, it isn't right, but boy, have you all been resilient and flexible with what you do, and thank you for your service. Back in 1994, just a quick history, as a business person and a gun owner, I became aware of the epidemic of gun violence that was basically resulting in 106 deaths a day in the country, 40,000 a year. And the more I looked into it, the more I realized that there's no surprise. I mean, I'm a gun owner, I believe in gun rights, but it was just no surprise that, you know, at thousands of gun shows and 33 states, you could buy a military-style weapon, a large-capacity ammunition magazine without a background check. So I set out to work with law enforcement, the conservative voice of law enforcement, and try and shift the conversation from banning or unlimited access to guns to how are kids, criminals, the dangerously mentally ill accessing firearms. What can we do to prevent that access without banning guns? And lo and behold, since 1994, in a bipartisan way, Massachusetts, urban industrial Massachusetts, has passed laws in 98, 2004, 2014, with 2 Republican governors and 1 Democratic governor, and we've reduced gun deaths by 60% since 1994 in the Commonwealth of Massachusetts by changing the conversation, changing public policy, and changing public health outcomes. Again, without banning guns, except for weapons like the AR-15 and the large capacity ammunition magazines that we are seeing are leading to the daily mass shootings of 4 or more people, not to mention Sandy Hook and Las Vegas. So using that same model, working with law enforcement, when we became aware of the epidemic of opioid addiction, we knew we had to do something different. The chief in Gloucester made a very bold statement to the mayor and said, we cannot arrest our way out of a public health crisis. He approached the recovery community and found and was educated about all the barriers to entry for treatment for the disease of addiction. And you can argue about whether it's a disease or not, but opioids change your brain chemistry. They rewire your brain so you can't feel pleasure without them. And I don't know, you know, everyone's addicted to something. Some are more healthy than others, whether it's working out, maybe less healthy is your iPhone, and even less healthy than that is some other things that we don't even need to discuss. But the issue with opioids is it's a chemical that is very, very powerful and goes to the part of your brain where you feel pleasure. It rewires your brain so you can't feel it without it, and you can't even make dopamine, which is what is the chemical that your body makes to feel pleasure. So it was a huge learning curve, and we soon realized that, one, you can't arrest your way out of this, and two, people need long-term treatment, not jail. And so we created what's probably the first pre-arrest diversion program. And starting out, we created a law enforcement council. We are strictly a law enforcement-based entry into treatment organization. We're a nonprofit. We grew out of the need to find ways to help people access treatment in the absence of the healthcare system doing its job, and we take our direction from our police council, some of whom are here today. The Plymouth Police Chief, Mike Bodieri, and Scott Allen from East Bridgewater are here and on the council. 175 people a day who woke up this morning will die from overdoses, and many more will be saved thanks to naloxone and the work that law enforcement and first responders are doing. You know, in a state like Massachusetts, more people die from overdoses. It's now up to 6 a day than gun violence and car accidents combined. You know, the numbers are staggering, and it's no surprise. I don't know if you all saw the Washington Post 60 Minutes expose, but if that isn't criminal behavior, where the biggest drug dealers in America are actually the pharmaceutical industry that spent $106 million over 3 years to undermine the DEA so they couldn't do their job in stopping online pharmacies and stopping the flow of opioids into your communities, I don't know what is. But 23.5 million at least need treatment, and only 11% can access it. The obstacles are amazing. You go to an emergency room with the disease of heart disease, diabetes, you name it. Cancer, you're treated with respect, you're given medication-assisted treatment, and your life is generally prolonged. And although there's no cure to those chronic diseases, there's a way to medically treat them. You present with the disease of addiction, you're shamed, blamed, and often kicked to the street to die. So we decided, police department in Gloucester, Mass. decided, with the help and support of the mayor, that the police department's open 24/7 too, just like the emergency room. And let's put out a call and say, starting on June 1st of 2015, anyone with the disease of addiction could come into the Gloucester Police Department with or without their drugs. And that was a very provocative thing to say. In reality, hardly anyone has come in with their drugs and paraphernalia. But it was just an example of how drastic the implications of the disease are. And we had to do something different, and it was incredibly disruptive, and it exposed a broken system of barriers for one disease versus another. And the stigma and shame and blame associated with the disease is a huge part of why there aren't cures and long-term treatment. So we were founded, and I am incredibly proud to say, I mean, we honestly didn't know whether anyone would show up. When the Gloucester police chief put out the call, come into the Gloucester Police Department, no arrest, no shame, blame, we'll get you into treatment, not jail, whether anyone would show up. The first person did show up from California, placed him into treatment within 12 hours. When people show up now, and over 600 people have come into one police department and all been placed into treatment same day, and if they relapse, they are told, come back. This is not a moral failing. You are a victim, oftentimes, of an industry that has aggressively marketed their product, an industry that has aggressively overprescribed the product, and then when you're addicted, there's no access to treatment. And I can tell you firsthand, having lost a nephew who had an MBA from Suffolk University and well-paid, but poster child, back pain, overprescribed, those pills, as you know, on the street, whether it's an Oxy 80 or a Perk 30, it's at least $1 a milligram per pill on the street when you're cut off from your doctor. So an Oxy 80 at $80 a pill, and you need 4 or 5 or 8 a day, it does not take long before you are breaking into everyone's home that you know and love and stealing in order to pay the habit, and then you're going to the cheaper heroin and fentanyl. And my nephew went that progression, could afford it, and then couldn't, and then ended up dying of a fentanyl overdose by himself. This disease knows no boundaries, and sadly, we have found that that it really wasn't an epidemic, like crack was an epidemic, but it was mainly black kids dying in the inner city. But when white kids in suburban and rural America started dying, it became an epidemic. And thanks to the work of law enforcement, you have begun to change the conversation, exposed the broken system and the barriers to treatment. And my guess is, over the last 2 years, we've placed over 600 people in one police department. We have 320 police departments in 31 states doing similar programs, and these are ones that have joined PARI. And we will disrupt enough in order for the healthcare system to start to change. And PARI was asked by the White House last year to come to Washington with 50 chiefs. We held a press conference at the White House. We met with members of Congress, and we helped change policy and get $1 billion for treatment. That was largely led by law enforcement. So, PARI is a free organization. For membership, we simply ask that you acknowledge that this is a disease versus a crime that needs treatment, not jail. We've provided startup grants for police departments, $1,000 to $5,000. We've provided free Narcan to police departments across the country. We did a partnership with the one pharmaceutical industry participant that I know of that is doing the right thing, and they gave us 10,000 doses of Narcan to distribute across the country. I mentioned how we have changed the conversation, but what we didn't really expect was how it would be embraced. Not only that we'd have 320 police departments in 31 states, including in Phoenix and Salt Lake, Anaheim. I mean, the list, it's large and small. What we have also seen is a reduction in ancillary crimes usually associated with addiction. I mean, it's no surprise. You're arresting and re-arresting and arresting and re-arresting and saving and driving someone to the morgue. So what we've seen is a 30% reduction in ancillary crimes like shoplifting, breaking and entering, smash and grab in Gloucester. I think if you talk to Tim Lentz, the chief in Covington, Louisiana, southern Louisiana, he would tell you that he's seen it at least a 20% or 15 to 20% reduction. And across the board, among all of our PARI Police Department partners, we've placed about 12,000 people into treatment, and this is just in the past 2 years. This is a map that shows where the police departments are that have joined, and pretty innovative stuff. So they're most of the police departments are doing an intake model, like inviting people in to their department. We are now placing people in Gloucester either over the phone or within 45 minutes. We have 300 treatment centers across the country who will take our people with or without insurance. They'll provide scholarships. And one of the things, an aha moment for us was, why is it possible that police are so successful in placing people into treatment versus family members? Because I can tell you that my brother, was struggling to find a bed. There was never a bed. But when a police chief calls or a police officer calls, all of a sudden, there's room in the inn. It's partly because those of you not in law enforcement like me, we grow up learning not to say no to cops. And believe it or not, treatment centers are the same. So use that leverage that you have in your communities until the healthcare system catches up, treats this disease like every other, and we work ourselves out of the law enforcement-based treatment system. In Massachusetts, we have roughly 60 chiefs around the Commonwealth, which has taken a huge burden off of Gloucester. I mean, we were having 1 or 2 a day come in. Now we're having maybe 1 a week come in because they're going to East Bridgewater, or they're going to Plymouth, or they're going all over the state. So there is strength in numbers. Like I mentioned, we have this model where, people can come in, but we also have an outreach model, which we'll get into as well. So again, it's an intake-based model, 600 people, and during the first year, the New England Journal of Medicine did a study of the Gloucester Police Angel Program. And it was, first of all, it could be the best validator in America as a research and medical public health policy journal, but incredibly, we found that Gloucester police were successful in placing people into treatment 94.5% of the time versus the healthcare system at 54%. Think about that. The police are almost twice as effective in getting people placed into treatment than hospitals. If that doesn't expose a broken system, I don't know what does. This is the New England Journal piece. It highly acclaimed and really gave us a pause to realize how broken the system was, more so than we even imagined, and the level of trust. So we have placed people in treatment, we've reduced crime in Gloucester, we have placed people into treatment dramatically more than the healthcare system, and we have had an enormous increase in trust. The outreach model. So Chief Fred Ryan in Arlington, Mass., 68,000 population, realized that the greatest sort of predictor of the next overdose death is an overdose save. So he started to make visits and require his detectives, when they were making an arrest of a drug dealer, when they got the phone, the computer, the client list, to have a plan when they take down the dealer to go make a visit with an embedded clinician in their department, go to the home of the user and say, we've taken your dealer off the street rather than find a new dealer. How about getting into treatment? And if you're not ready for treatment, here's some 4 milligram Narcan, train them on how to use it, leave it with the family if the user wasn't open to it. And it was the warm handshake from law enforcement. Fred Ryan was seeing in his community roughly an overdose death a month before he started the program. And believe it or not, I mean, since he started, he finally had his first fatal this month. So in 2017, 1 fatal. Went out to Michigan, met with some members of law enforcement in Michigan, came away with every single law enforcement agency, police department and sheriff's department in Macomb County, Michigan, joining PARI. Their program is Hope Not Handcuffs. They're placing people all over the county, and it's our first state police. The Michigan State Police are rolling this program outreach model and intake model. Anybody can go to a state police barracks in Michigan and get into treatment. Arizona, we started in, this is Chief Ryan from Arlington. We started our first Arizona-based Angel program in Phoenix. And now the governor, Republican Governor Ducey in Arizona, is rolling it out statewide. Maryland, Anne Arundel, Maryland, we now have 38 police and fire stations, all as intake centers for folks with the disease of addiction who want to get into treatment. All of this stuff is on our website. It's parausa.org. We've got a great resources link. So any of this, these models, we've got policies and procedures you can take a look at. And I would highly encourage you to take a look at it, because not only, is it fulfilling your mission of serving and protecting, you're saving lives, every single day, and as importantly, exposing this broken system that has led to an epidemic. Plymouth, Mass, run by Chief Baudieri, they have drop-in centers, they have home visits. They are now, it started in 1 or 2 police departments in the county. It's now every single agency within the county, so they are sharing information. They've probably got the most robust real-time database. And they're not just helping the folks in their county, but it's a great model for a county-wide program. We were working closely with IACP, with Police Foundation, with PERF, and with the White House Office of National Drug Control Policy on a regular basis. Sometimes you guys, we're all too close to what we do sometimes, but I will give you a sense of the perspective that law enforcement, the conservative voice of law enforcement, stepping into what has been a public health crisis for decades, but is now, because of your voice, being seen as a public health crisis that needs a change in public policy. You guys are the ones that are exposing it, which is having a huge impact in Washington. And one of our greatest boosters, believe it or not, is now the White House. Now, we'll see if they actually put funding to it, but I can tell you that the acting director of the White House National Drug Control Policy, we talk to on a weekly basis. He's here at your conference, and this is one of the programs that he lifts and highlights, because it's members of Congress who are really the targets, and it's you guys that they listen to more than others. New York Times recently did a lead editorial, and 8 points on how to deal with the opioid epidemic, and PARI was number 2. Treat, not arrest. We have a law enforcement summit coming up at the BU School of Public Health and BU Medical School on December 5th and 6th. We would love you to attend if you want to learn more. It's really going to be a law enforcement-based opportunity to share best practices, learn how the various programs work, and hopefully expand. So with that, I can just tell you that what you do every day, and as hard as that is, I think this is a tool that is really worth considering, because I can only imagine how burnt out you and your officers get, not being able to help people in your community, and just understand that this disease of addiction is really hard to break, but the shame and the blame and the stigma is an enormous barrier, and like I said, there's access to treatment for every other chronic disease but this. But within time, with your help, I am a firm believer, it's one of the things I'm most optimistic about, is that with the continued enrollment and support and voice of law enforcement, public policy will change. This is not like gun violence, where people say, oh, criminals are always going to get guns. I mean, frankly, it's not that complicated. And Massachusetts showed that you can help reduce injuries and deaths from guns and dramatically reduce gun violence just by making it harder for kids, criminals, and the dangerously mentally ill to get guns. Well, the disease of addiction, you know, it's not a simple solution. It's complicated because of how these drugs rewire brains. But I can tell you that we are seeing a lower relapse rate as a result of the pre-arrest model, where law enforcement is helping people versus arresting people. And in many cases, people have said, my police officer or my police chief was the first person that actually cared. And that just pays dividends on all other fronts in the work you do. So we're going to do questions later?
Yes.
Great. Thank you so much for the opportunity.
So we will have time for questions at the end. I'm just going to have our next presenters begin so that we can make sure we get all the presentations in. Sure.
Hi, good afternoon. Is that on? Okay. So my name is Emily Sirico. I work with West Care Foundation doing business as East End Community Services. We just recently merged with a larger nonprofit, and I'm going to go into that in a little bit. But I just wanted to thank John for really setting the tone, like, quite perfectly for what we're going to talk about today. I work with a non-for-profit, and I cannot tell you how much law enforcement has really been such a game changer in our community as well. If it wasn't for them, I think we'd have a lot more lives lost today. So I just wanted to acknowledge any law enforcement in the room. And I just feel very honored to be sitting here with Major Johns, invited to be a part of this presentation.
And I'm Brian Johns from the City of Dayton Police Department. I've been a cop for 25 years. Back in 2013, I got promoted to the rank of major and was assigned to the East Patrol Operations Division that we'll talk about today in more detail. And when you watch the nightly news and they say that Dayton, Ohio is the opiate overdose capital of the United States of America, we'll talk about East Dayton, and that's where it was all occurring at. It is now kind of spread out some, but that was really the epicenter of our issue there in East Dayton. The strange thing is I also was born and raised in East Dayton, and I've lost 2 cousins and numerous friends to opioid overdoses. So really it's personal to me, and we take it very seriously and do all we can do to help people to get recovery that is so important nowadays. So thank you.
Yeah. And just wanted to point out, this is actually a picture of our city, the Miami Valley River, and just kind of a shot of downtown of Dayton. Oh, man. Maybe. Back. So as I mentioned, so I work for a non-for-profit, just a little context of who I am. So I have a master's in public health and a background in social work, actually. So I'm not with a public health agency, and I think that's really important to mention because I was actually hired on in 2015 because my executive director was seeing that our local public health agencies were not addressing this as an epidemic, as John had alluded to earlier. And so how could we, from a community standpoint, really bring the public health perspective in to this crisis our community was seeing? So we've been around in East Dayton since 1998. Our focus has been community development, prevention, education. We really focus on nurturing children towards success. When we started in '98, we actually surveyed the community and asked them, how can we work alongside you? Not coming in to rescue or really to change anything, but there was stresses of poverty. And so at that time, our neighbors had told us, our children don't have any dreams. Could you please give them dreams? And so from that, it's really stuck as part of our mission. We try to break the cycle of generational poverty. If you can see, in this slide, this purple area here is East Dayton. East End is located right in the heart of that, but it's about a 2-mile radius and where the epicenter of the opioid crisis has been in our community.
And in 2013, East End applied for and got a grant, a burn grant for this area here. And it was actually right in 2013, and it was actually focused on crime hotspots. And what we found is we had a large numbers of people who were actually, I know John alluded to it, who were doing burglaries, B&Es, theft from motor vehicles. And when we actually did that hotspot grant, we actually began to look into it. What we found was those crimes were actually symptoms of the opiate epidemic that was just starting there in East Dayton. So, we had people going out and stealing. I remember talking to one guy one morning. He'd broken into a home, and, every morning I need coffee just to start my day. He goes, every morning I wake up and I need $100 worth of heroin just to begin my day to get well, as he put it. And he didn't work, so he stole to finance his addiction. And we knew if we were to be successful, especially in reducing crime and overdoses, that we had to address the opiate epidemic. I had no clue then that it would get this bad. I kept waiting, it can't get any worse than this, but it actually did. So, we knew we had to address that issue. And Burn was great. They let us change the last minute and really focus on some of the programs we're going to talk about today to try to address that opioid crisis.
So, my role was really to bridge this gap between community and law enforcement at that time and public health. Even though law enforcement was pushing and on the front lines, there still was not this strong connection between our community and our law enforcement. And so how could we kind of be we're a relationship-based organization. We had trust in the community, and so we were kind of that center to bring the law enforcement side, kind of understand where they're coming from and how civilians can work together to really address the crime issues at the time, but then later understanding that the root of all that crime was really addiction. We needed to develop strategies around that. So this is just, so WestCare, I mentioned, we recently merged. Their mission is to uplift the human spirit, and so we were actually invited to talk with their senior leadership about a year ago, thanks to a partner from Wright State University, our local university that works with us translating research to practice, and they didn't realize the severity of the opioid crisis that we were dealing with, and their history has really been, for the last 40 years, developing comprehensive treatment that is person-centered, that looks at both mental health issues as well as the treatment side with addiction, all addiction, not just focusing on substances. So they were very interested in what we were doing from a prevention and asset-based model, and seeing how we can work together to not only address the issue in our community, but hopefully address it in other communities across the country.
Yeah, and this is an overhead map of the Dayton, Ohio area. And as you can see, the east side of Dayton is in the right side there in a black circle. So a couple slides ago, we saw like the NRZ and the burn grant, and that's that area there, like primarily like our East 3rd, East 5th Street corridors. And you can just see the large cluster of overdoses that were occurring. Now this map here, those red dots, those just stand for, those show the number of Dayton police Narcans, not our fire, just our police Narcans. Through 2016, that we'll discuss a little bit later. But clearly, this was our focus area for our initiative, and we'll talk about things today like our needle exchange and GROW and our front door program, but they were all focused in this area here to try to make an impact on those overdoses that were occurring. This is our overdose death rates in Dayton, Ohio, Montgomery County, and these are county-wide numbers, but the lion's share of these are from Dayton. And you can see there in 2013, when we began our effort with Burn, they really began to grow that year. In 2014, we began to actually track not just overdoses, but overdose-related crime for some of our efforts. And Dayton Police began carrying Narcan in 2014, which was very good, because in 2015, probably as most of you know, our heroin epidemic became a fentanyl epidemic. And people started overdosing quite frequently. If it wasn't for the Narcan that we had, I would hate to see what the death toll is now. In Dayton, Ohio, you can't hardly sell heroin. We have phone taps going where dealers can't move heroin because people want fentanyl, and they call it fire in Dayton. 2016 was a record year for us at 349 in regards to overdose deaths. And that 2017 slide there, that is only through 6 months of data. So actually, by I believe it was May 14th, we'd already surpassed our overdose deaths for all of 2016. But there was some good news. There is some good news in the horizon. This is a month-by-month breakdown of overdose deaths in Dayton for 2017. We hit a high at 81 there in May, and really made a lot of national news with our coroner's office, who actually had to bring in refrigerator trucks. There were so many bodies at the morgue and crime lab. But we have seen a reduction since May, and we hope that actually continues to hold true. We are seeing more crystal meth on our streets. But we talk about fentanyl. The first 100 deaths of 2017, 99 of those were fentanyl or carfentanil derivatives. So that was a huge issue for us, not just for the overdoses, but when we talk about Narcan, we were Narcaning people 8 and 9 times just to try to bring them to somewhat of a semi-conscious state. And even then, I think the record was 32 doses of Narcan by the time they got to the hospital, and ER took care of them.
Yeah, and I just want to point out something here. You know, our chief of police, Chief Beal, and the Dayton Police Department is the reason why all of our officers now carry Narcan. And I'm not going to embarrass him too much, but I just think that needs to be said. It was one group that took a stand and said, we're going to do this. And so they started that in October of 2014. And if you look at this, it says 2017 accidental overdose deaths. This is actually from our epidemiology department and our local public health agency for this year. This was from request of law enforcement, community members, stakeholders saying, we need to understand these overdoses, what's happening in our community so we can try to slow it down and reduce the number of deaths. But I just want to point out, public health, our local is now much more on board with things. I don't believe that their intent was not to be on board. I think it just didn't know how to act, as many of us did. But I think one thing I can acknowledge with law enforcement, working very closely, you all just act, right? I mean, you think and you act, but you respond. And instead of sitting in meetings and processing, and I mean, that's great, but at some point we have to move to action. And I have to say, now we have more stakeholders working together towards action. So this has not been confirmed by our coroner's office because we're about 4 months behind, but these numbers are about right. So we're at a total of 512 as of October 12th, and it gets updated every Friday.
And back in 2014, the burn grant took place in 2013. In 2014, we actually started to provide recovery services for those people struggling with opioid addiction. And actually, I know Gloucester did do great work, but I'd say that the first things that we did were like walk-in services, where we actually went to the media, we did sound bites, we sent out flyers, social media, and asked folks to come to us. We'd have recovery folks there, peer support who've been through the addiction process and recovered from it. But we didn't get a great turnout, so I'm very honest and upfront about that. The first one we had 3 people show up. The second one, we had 1. And we actually, our providers far outnumbered those folks coming to us for recovery. And that was the issue that we'd had. So we had to kind of change our operation and actually see how can we actually go to them and bring our services to them where they're at, where they live, in their neighborhoods, places they go, and families that they're associated with. And really, we had a lot of work to do that to identify those folks who were struggling. And this is what we kind of came up with. I tell you, the first one was actually written in a notebook by hand, but we actually began to track in 2014, in January, overdoses, non-fatal overdoses. If you overdosed and survived, you made our list. If you committed a crime and went to court and said, you know what, I'm an opiate addict and that's why I stole that stuff, you made our list. If we went to your house on a call and your mom or whatever says, hey, you know what, my son's an addict and he needs help, you made our list. If we stopped you in a high drug area trying to buy heroin, you made our list. And what we did, that list that we initially have is now this today. This is actually a daily email that we sent out to our department that documents these people who are involved in opiates, has their photographs there, where they overdosed, where they live at, what they look like, so when we go to their house, we know who it is, how much Narcan was used, so kind of telltale, was that a fentanyl or heroin overdose? But we actually use this information here for a lot of the things that we do that we're going to discuss today. And these here are some of the programs we have put into place since 2014, and we're going to try to get to all of them if we have time.
Yeah, so we have a conversation for change. If you look in the back table, I know Jessica mentioned there's cards, and we're going to talk a little bit about that program that started in 2014. And then we had the CarePoint Syringe Exchange Program, and that actually was between law enforcement and our local public health agency in November of 2015. And then the Dayton Police naloxone deployment, Major Johns will talk about our front door program in 2016 of June, and then GROW, Getting Recovery Options Working, in January of 2015, and then our Community Overdose Action Team, which is called COAT, that is led by our local public health and local mental health board. So a conversation for change. This was an initiative that started from a grassroots effort, right, with community members representing from East End Community Services, Major Johns himself, our Dayton Mediation Center, which does conflict resolution, some university partners, and at that time, Family of Addicts, as well as a support group, to try to identify some type of program, really understanding why people were not accessing the services that we knew were readily available, which highlighted the fragmented system even at that time.
You know, yesterday when I checked in here at the IACP, I saw Dr. Kennedy walking the hallways down there, and you know, his big fame is Operation Ceasefire out of Boston. And for years, the Dayton Police Department has a program similar to that called SERVE. It's a community initiative to reduce gun violence. And we have had some success with that. So we thought, why don't we take that loose concept of SERVE and try to use it for the opioid epidemic. So, how SERVE works, you identify those people in the community that have guns and do gun violence. You call them into a courtroom setting. You try to get them services and say, hey, man, you need to straighten up, or if we catch you again, we're going to throw you in jail. Now, our Currency for Change is much different than that, but it's the same concept. So we identified those folks in the community struggling with addiction. We had what we call a community call-in, where we actually had in the community at like a local church they may have services from, or at a neighborhood center. There's no cops there. I'm there, but I'm in like blue jeans and a T-shirt, and we actually have them come in a community setting where there's actually support people there to help them. We have peer people who are there who have been through the recovery process and try to get them the help that they need in more of a loving and type open setting where they can discuss the issue through motivational interviewing.
Yeah, and he's right. It's a non-enforcement event. If I see any officer in uniform, I usually throw them out because I'm like, don't deter anybody from coming in. Although that is changing now, the image, because law enforcement's role has been changing. But there was one time between media and law enforcement, we had to be very strategic of how we did this, not to create an internal barrier. But I just want to highlight the components of this program is really education, conversation, and overdose prevention. So it's a 2-hour event that's held in a local church. And what we do is the data that Major Johns was talking about, that list, the Dayton Police actually sends out all those notifications to those that have overdosed, and they put East End's return label. So if there's questions about the event, or I got this letter from East End, we have that trusted relationship again. And I will tell you, the evaluation shows that's how we bring in the most people to these events. But for the overdose prevention, we partner with Project Dawn, who does our training on naloxone and provides free kits, because we want to make sure if the person's not ready to access help, at least they can have some skill or some training, that family member, to save that life when they are ready. So that's one component. The other part is we have a chemical dependency nurse liaison that comes in and talks about addiction as a disease to reduce the stigma, right, for asking for help. And it's really targeted not only to the ones struggling with addiction, but that family and friends, because we know the more that they're involved, they can help that person access that treatment. And because our systems are so fragmented in the healthcare, I love how John reflects that, we decided to create an integrated system. Imagine of all the treatment providers to come to them. So instead of calling and waiting 2 days, 3 days, maybe 6 weeks in some cases to get an appointment, you could develop that personal relationship, and so have everyone right in the same room. And then we have people share their testimony that are in long-term recovery to say, there is hope, you can get help, but and not everybody's path is the same. And so the idea is to really individualize that process And the conversation is the center. So we work with Dayton Mediation that's trained in motivational interview techniques. And the goal is really to make some behavior change, ideally towards treatment, but we take a harm reduction approach. If you're not ready, okay, guess what? Well, there's health screenings happening, HIV, Hep C, just anything that we can try to make it a healthier community and that individual ready to make that change. And then this is just a group of the partners. It's evolved. It started with about 5 people, 5 partner agencies, and it's grown to over 30. So we have a lot more buy-in from our community. We have Dayton Municipal Court, adult probation, the health side, our mental health board. Actually, our mental health board were the ones that funded this in the beginning. And then Family of Advocates, which is a huge support and advocacy group for the entire family. And you obviously see Dayton Police there in the center. So this is an example of our flyer. Our next one is on Thursday, November 16th. You're welcome to come to Dayton, Ohio. You just need to let me know ahead of time, and Brian, because he makes special brownies.
We do, yeah, we have dinner
We
for
gotta make
them.
sure we
and,
have to
yeah.
have enough.
Yeah.
Yeah, that's the other thing I didn't talk about. So 2 of the incentives, we do give a Kroger gift card if you complete the program, and then we provide a healthy meal during the program.
Usually pizza, I'm not sure how healthy it is, but
Yeah,
it's pretty
we're
good.
working on that, getting a few more funds. So just some quick outcome data. We're still in the process of collecting for 2017, but from 2014 through 2016, we've had 16 conversation events in the community. 452 people have accessed those events for themselves or for a family member or a loved one. 109 of those individuals had mental health or AOD closed or active cases where they accessed treatment after the event. And then 403 have been trained by Narcan by attending those. So we're reaching more people that way. So here's another event that Major Johns is going to talk about, the front door.
Yeah, and this is actually my most favorite one. It took a lot of hard work to get this actually up and running. Not too many people want a community-based opiate recovery center right actually in their backyard, but this one actually is. This is the front door program that we call it. If you look, the mural on that building, those are poppies. This mural was actually done by a young artist in our community who's in recovery, and she's a great artist. But if you look to the left of that side door there, that's a description, or I guess a painting of her fiance. He was an art teacher in Dayton, and he overdosed and died on heroin. But this kind of is in his honor, this mural, and that decorates the outside of our front door recovery center right there in that targeted area where all the overdoses were occurring there in East Dayton. This is also, I just want to mention, this is actually what they call an interactive mural. Folks can come and put the name of their loved one who died from an overdose in the vines of the flowers.
And so this was part of that burn grant that we mentioned. One of the strategies was to bring treatment and the accessibility closer to home. So we were really fortunate to have an active community, a neighborhood association that really worked with us to say, hey, we need to educate our neighbors. This is necessary. And how do we partner with the treatment provider as well as the police on this?
And what made it so great is the location. I mean, it was right there in the middle of all the overdoses. There was really no excuse not to come. You could actually walk there from East Dayton. It was on a bus line. If you had no insurance and no money, they would still bring you in and help you out and get you signed up for insurance that way. It also is great for law enforcement because so many times, I mean, we talk about it, and the mechanisms to get treatment were so. They were horrible, to be honest with you. If we had come across somebody who wanted treatment right now, there was no place to take them. They had to wait 3 weeks. And 3 weeks is a long time for somebody that's addicted. But this actually gave us a resource 24/7 to take somebody to who wanted recovery. If it was 8 to 6 during normal business hours, we'd just take them right there. If they didn't want to come with us and wanted to go later, we'd actually give them a card just like this. It's a law enforcement special card that we had for our law enforcement officers. The cop would give them the card. They could go in at their leisure and show them this card, and they'd be taken in no matter what. If it was 3 o'clock in the morning and we had a guy that wanted recovery or a lady, we had a law enforcement hotline number that we would call. They had recovery homes stationed throughout East Dayton. We would take them to the recovery home. They'd actually begin that detox process with medications, then transport them the next morning to the front door to get more follow-up services. So that was really great for us to have. We have had 125 people go through the front door program. It's been in place a little over a year, but I will not lie to you. I know, like John mentioned it, trying to keep people to stay in recovery is tough. You know, I've read anywhere from 7 to 10 stints in recovery in regards to an opiate addiction before they finally start getting things back on track, and I would probably say at least 7 or 10, because they'll come, they will leave, we take them back, and we just gotta keep doing what we can until they actually stay in treatment.
And I think what it highlights, again, we don't have a continuum of care services in our community. You know, the default detox is our county jail. We have 56 people today detoxing in there, which in my opinion is completely inhumane. If it was a different condition, they would have physicians and medical staff. Although that's shifting, you know, that was 76 a day, it's gone down, but our crisis center in our hospital would not take people unless they had a mental health diagnosis in addition to that addiction disorder. That's shifted, but still, this highlights that someone had to step up and do something. And so, to John's point, people do listen to officers. I've been there. I'm like, they always open the door for you. Not the same on the social work side always, but it highlights we had to do something. And this treatment provider, although it's not the end-all solution, gotta hurry up.
Yeah.
It was a start, and it really did push some of these really non-for-profit and the public sector to move a little bit faster. So, grow. We're going to talk about this initiative. So, as Major Johns mentioned, there was still, we weren't able to catch everyone, right, through this front door process. So, actually, Major Johns is the one that started this type of outreach. He used to email a small group of us of all the fatal overdoses, and you would see them pile up and pile up. And he's like, we got to do something. We're still missing so many people. And so in January of 2015, we started this. It's based off of the quick response team model, but it's called Getting Recovery Options Working. And you see Major John's in the back there squinting. I'm in the center. And we have our famous peer in recovery here, Billy. He loves selfies. That's like his big thing. But that's how he connects to others that are seeking services. And then he works with family of addicts. But the idea is to educate and connect people, help them navigate this fragmented system. And what we do is we actually bring a bag out with us. And it has, again, a harm reduction approach. We have different levels of support in here depending on who we talk to or what is the concern. If they're ready for treatment, that officer will take them right away into treatment. If they're not, we leave them with Narcan information to be trained on Narcan. Now we have officers that can train on site. That just recently changed. We also work with trying to get them into a support group. So sometimes they're not ready for that treatment, but if they go to a weekly support group, that's a way to try to motivate them. And then we also have information on our needle exchange program.
What's that?
What about, I know we only have a few minutes, but what about medication-assisted treatment?
The front door is MAT, but they also offer 12-step.
Right. The front door, the idea is so we individualize it. Not every single treatment option is the right one for everyone, right? Not one size fits all. So what we do is we've got the partnership with an MAT provider as outpatient.
I was thinking more about the GIS, they have the operational state view, Massachusetts, New England, Ohio County. I saw your very nice GIS of police, not EMS or fire. I didn't see hospitals, I didn't see treatment centers, I didn't see
Yeah.
medication assisted. These doctors who are certified have DEAS.
So we've requested that. We've actually requested through different coalition efforts from the mental health board side of things. Can you have a system where it would be live and people could access and know how many beds are available? Or whereas that was back in 2015, we're still kind of waiting.
We're waiting.
For these pieces to come. Yeah.
Yeah.
So, no, you bring up a really good point. So, just real quick, so it is a multidisciplinary team that goes out. We have the peer that is in long-term recovery, police and fire, a recovery specialist, or someone from the community. We try to respond within 72 hours of an overdose to get that information to prevent the next overdose. And then we also respond in progress overdose calls as well, and then provide the naloxone training and furnishing. Do you want to talk about the
Sure.
addiction officer?
Yeah, we'll go real quick. In 2015, we do have we had so many overdoses, we actually had to take a full-time officer and assign them to grow. So their entire job is to follow up on overdoses and try to get those folks into treatment. Our fire department also came along and helped. We have a full-time medic that comes out with our police officer. So when they come, they can also do in-house Narcan training and leave a kit at the scene at the home before they leave. And here are some of the numbers there. I know we're running short, but those are the numbers there in regards to the grow. They also respond to in-progress overdoses and administer Narcan when they arrive.
Right, and just to note that we've been able to connect since this started officially with that officer in 2017 and tracking data, 73 people into treatment. So we're making some progress.
And I'll try to hurry. This one here kind of causes some heartache to folks. In 2015, we had a skyrocketing number of hepatitis cases. We had officers getting stuck by syringes. So the city of Dayton did partner with Public Health and the Life Enrichment Center, which is also in East Dayton, for a needle exchange. I got to work 2 days at one of the largest needle exchanges in the country and brought that information back, and we've crafted our needle exchange here through Public Health. It has now expanded from one site to 3, and there'll be a mobile exchange by year's end. The one big thing about the city of Dayton, they did not want to be involved in just a strictly pure needle exchange. There had to be some sort of tie-in to recovery services and Narcan. So that is exactly what we actually did, and we'll talk about some of those just real quickly. But we had it actually took an emergency ordinance by a city manager to have that done. Ohio law has changed, but back then we needed actual emergency ordinance. This is the CarePoint patient card. So if you go to the needle exchange, you're given one of these to track what has been given to you. And if you are on the way to or from a needle exchange and you're stopped by police, you're not arrested or charged with that card. This one I talk about this a lot to police officers, and it drives them crazy, but you can kind of see some of the things here that we actually give them and the number of needles that are handed out so far. People, when they hear we give them actual cookers and things like that, some folks disagree with that, but this is about harm reduction and stopping the spread of hepatitis, and if you share a cooker with somebody, you're going to pass that along.
Yeah, and it protects the first responders as well that are saving lives.
And we talked about tie-in to recovery services, and this is the referrals they make from CarePoint to recovery. They also do testing, as you see on the right, for HIV, hepatitis. We have a lot of open wounds from IV drug use, and they take care of that as well. And lastly, we talked about Narcan. We began our Narcan in 2014 at Dayton Police Department. Chief on down, everybody is trained with Narcan. Those folks in East Dayton usually carry 3 kits. Each kit has 2 doses in their kit. We have just recently started a new program in East Dayton where we'll actually come out. We'll also, we'll come out and Narcan you, but we'll also leave a Narcan kit with you and your family and train them how to use it. If we just go on a family trouble and someone there has is using opiates, we will train them. It takes 5 minutes, give them a free kit, and all those kits are provided by Public Health at no cost to the Dayton Police Department.
Yeah, and I have to say, this was really Major John's push. It was when we were doing the Grow Outreach, one of the calls that we went on. There was, the husband had overdosed. We were talking to the wife. She had a 2-year-old grandchild in the home, and luckily she used the Narcan kit and saved him, and he had asked, do you have another kit? Okay, well, she said, no, I don't. Could you go get trained? She goes, I don't have access to a car. I really can't. So he went to his car and gave her his kit, and she was able to use it again in 2 weeks, saved her husband, and at that time we did another follow-up to that home. Husband was brought in, she admitted to using, and 4 other family members. They were the first family actually to come through the front door, and they're still in recovery today. So if that's not a testimony itself, you never know when you're talking to one person what the impact of that conversation can have.
And this is the very last slide, so I'm sure you're all very happy. This is our Narcan numbers from September 2014 to present. We've actually used 1,306 doses of Narcan and saved 850 lives in that process. And unfortunately, we did lose 35. And there's our information. If you need to get a hold of us or call us or email us, just feel free to do so. It's very important to us. So. Yes, sir.
So this gentleman next to me described the situation as a disaster, right? Okay. I agree with that, and I think it's causing us on the street level to look at things differently and do things in a better way. And you mentioned something about the pharmaceutical industry, FDA tasked
Sure.
to police lists upon lists of chemicals, of which some now are considered medications, and they're all from the family of heroin. All these painkillers are in the same family as heroin, but heroin is a Schedule I substance, no medical known use, but we're using the same family of medication to treat pain. So they've got their hands and grips in everything. And my point that I'm trying to get to is I think we need to keep our eyes down and up and take a look at what chemicals are scheduled and why. Because if you haven't looked yet, check out ibogaine and what you can do with ibogaine to treat opiates. It's a Schedule I substance. Ayuska and what's going on with MDMA, also known as ecstasy. It's a scheduled substance. And they're using the cure word for ecstasy and PTSD. So we really got to look at what we're doing with the
Sure.
scheduling system and how it's impacting people and who's dying because of it.
You know, what I've learned is that, you know, heroin is horrible, so is fentanyl, but we're trying to put mechanisms in place for the new drug down the pike, because there'll be something different going to come up. And if we can get those things in place and keep them in place, maybe the next drug epidemic that takes over our country, we're better prepared to deal with it as opposed to 3 or 4 years later when I think they said we have more deaths from opioid overdoses in the Vietnam War. And it's amazing, you know, it's amazing. Yes, sir.
Oh, wait,
I'm just gonna, I just want to make sure that everybody who feels like, I just want to thank our presenters and give them a round of applause. We're going to hang out here and answer some questions, but if you have to leave because the session is technically over, please feel free. But I just wanted you all to be able to join me in thanking them and give them a round of applause.
Thank you.
I don't think anybody has this room immediately, but we are going to hang out here for a few minutes and answer any remaining questions since we did run out of time. It's really up to them.
yeah, if people wanted,
Oh,
I'm sure everybody would like to hear from them.
yeah.